Namaste. A very good morning from India. I'm Shobha Shukla and I welcome you all to this special episode of NTB Dialogue Summit hosted by CNS in lead up to the World TB Day 2024. Joining us today is a super panel of experts from Bangladesh who will share with us what Bangladesh is doing for finding all TB, treating all TB, and preventing all TB in order to end TB. They will be in conversation with me and my dear friend Nurul Islam Hasib, a very senior journalist from Bangladesh. Nurul is senior correspondent with Dhaka Tribune and is former secretary of Dhaka Reporters Unity. I am honored today to welcome Dr. Pronab Kumar Modak, Umme Tasnim Maliha, Sarder Tanzir Hossain, Dr. Shayla Islam, and Mr. Sumit Mitra. Dr. Pronab Kumar Modak is Deputy Program Manager Training at the National TB Control Program of Bangladesh. He is also the focal point for drug-resistant tuberculosis. Umme Tasnim Maliha is a microbiologist with National TB Control Program of Bangladesh and supervises the divisional labs under NTP lab networks. Sarder Tanzir Hossain is Senior Project Officer with Stop TB Partnership. He is a public health expert and was formerly a part of Global Laboratory Initiative, Stop TB Initiative at World Health Organization. Dr. Shayla Islam is Associate Director for Communicable Diseases at BRAC, which is now known as Building Resources Across Communities. BRAC is a non-government development organization which works with marginalized and hard-to-reach communities with a special focus on women and children. Sumit Mitra from India is a thought leader on point-of-need and point-of-care diagnostics. He is president of Molbio Diagnostics. There will be 2 rounds of discussion with our experts from Bangladesh, followed by special remarks by Sumit. There will be a Q&A session after the discussions. Participants, please type your questions and comments in the chat box even as the discussion continues. Also, please keep yourself muted while the panelists speak. Without any further ado, let us begin with the first round. As we all know that as per the WHO Global TB Report 2023, out of the estimated 379,000 TB patients in 2022 in Bangladesh, 262,000 were notified. That is, 70% of them were notified. My question for all the panelists is, how can this gap be bridged and TB diagnostics, treatment, care, and support reach everyone in need? What is Bangladesh doing and how is it making a difference in reaching the unreached? I would request Dr. Modak to initiate the discussion, followed by Umme Tasnim Maliha, then Sarder Tanzir Hossain, and Dr. Shayla Islam. The question is the same for all of you. And I think it is in the chat box. I will repeat the question. How can the gap be bridged and TB diagnostics, treatment, care, and support reach everyone in need? Yes, over to you, Dr. Modak.
Sorry, am I audible?
Yes, you are audible, sir.
Okay, my line is a little bit unstable. So last 2 minutes, I'm not hearing anything. Just connected right now.
Okay. So should I repeat the question?
Yeah, sure.
Yeah, okay. We know that as per the WHO Global TB Report of 2023, out of the estimated 379,000 TB patients in 2022 in Bangladesh, 70% were notified. So how can this gap be bridged and TB diagnostics, treatment, care, and support reach everyone in need? And what is Bangladesh doing in this regard?
Okay.
Yes.
Thank you for your nice questions. So basically what happens from the government side, National Tuberculosis Control Programs play the key role to eliminate TB from Bangladesh. And our government commitment is that to make a Bangladesh free of TB. So coming back to the point, how to make the free TB from our country. So from the TB control program, we take too many initiatives from that. The data you show, it is basically 2022's data. In this year, in that year, we are diagnosing a little bit low number of cases. The estimated from the WHO, is the projection is that almost 379,000 cases we have to diagnosis. Ultimately, able to diagnose too many cases. Near about 2,000, around 100,000 cases were not able to diagnose and treated, of course. So there are some reason in 2022. If I share the data of 2023's data, just last year data, it will be published very soon through the WHO. You will find that we are able to diagnose more than 300,000 cases by 2023. But again, there may be some gap regarding the estimation and ultimately diagnosis. So we, from the NTP Bangladesh, we have initiated too many steps. First of all, we are introducing the rapid molecular diagnostic tools, because we are starting from the microscopy-based diagnosis from around 1993. So after that, too many diagnostic tools are coming and recommended by the WHO. Right now, WHO's policy and guidance and recommendation is that we have to use rapid molecular diagnostic tools, so that these diagnostic tools are basically more sensitive. So we are able to diagnose too many cases, the cases from the presumptive one. So previously we miss a lot of cases when we use the microscopy-based diagnostics. But right now in our country, we are able to install around more than 600 molecular diagnostic tools right now. And by this year, our plan is we have to install more than 800 molecular diagnostic tools. So when we introduce those molecular diagnostic tools, we are able to diagnose more cases. Basically 20% almost cases, those cases are basically missing. We are assuming we can diagnose those cases. Not only we are able to diagnose the TB cases, when we diagnose the TB cases as a TB, we have to treat those patients. So previously, when we diagnose through microscopy, basically for the treatment purpose, we are treated those cases as a primary treatment regimen. That means sensitive regimens, because for the treatment purpose, we are not knowing the patient's resistant pattern. So we are treat them, and in some patients who are basically initially resistant cases, they are not getting well after giving them the treatments. So right now, when we are starting using the molecular diagnostic tools, we diagnose too many cases who are basically TB patients, and simultaneously we are able to diagnose initial resistance, the first line drugs, especially rifampicin resistance. So when we diagnose the cases as a TB, and those patients who are also diagnosed as a rifampicin resistant, so we treat them as a resistant treatment pattern. That means we use to treat those patients second-line treatment regimens. So that is one of the key innovations. So almost in the Upazila level, we cover all the Upazila health complexes under those molecular coverages. Again, for the availability we have in the TB control program with the help of our partner NGOs, we have too many peripheral laboratory also. As those laboratories is out of the Upazila health complex structures, so it is very difficult for us to scale up the gene expert like molecular technology out of those Upazila health complex structures. We call those diagnostic centers as a peripheral labs. So all over the country, we have almost around more than 400 peripheral labs. Basically, we are based on microscopy basis because we are not able to previously the installation of molecular technology over those peripheral labs. But whenever the TrueNet, one of the molecular technology is already in the market, and WHO already recommended those technology. So after when WHO recommend this technology, we already installed 38 TrueNet molecular technology in the out of those Upazila health complex, basically cover in the peripheral laboratories, and more than 100 TrueNet we are waiting for the installation by 1 or 2 months. So out of those 400 peripheral laboratories, we already able to cover 150 areas by the molecular technology, especially TrueNet technology. So this is the great initiative of the TB control programs, even though, again, so when we are use those molecular technology, the certain percentage of our presumptive cases were not able to diagnose through molecular technology because the number of presumptive estimated presumptive number is huge, because last year we have some data, almost around 3 million presumptive per year we have to test it. So this is a huge number. So we have to test them 20 to 30% presumptive cases. We are basically rely on microscopy. Till now, we are trying to minimize the gaps. So again, we revise our policy from the TB control program, because when we use those microscopy, we are able to diagnose the TB cases. Yes, some percent of TB cases will be missed as we are using microscopy. But when we are able to diagnose the TB cases, we use the molecular technology to know about the resistant pattern. After knowing the resistant,
We are losing your voice. We can't hear you. Maybe some connectivity problem at your end. We're not able to hear you.
So over from my side.
Okay. Is that all, Dr. Modak? Do we move on to the next panelist? Hello? Okay, can we now hear from Umme Tasnim Maliha? Her views and thoughts, please.
Hello, am I
Yes, you are audible.
audible?
Yes. Audible, yes.
Hello?
Hello,
Hello,
hello.
am I audible?
Yes, you are. Can you hear me?
Oh, okay. Thank you,
Yes,
thank you.
yes.
Thank you, Shobha, for inviting me and giving me the opportunity to speak in such a forum with such experts. And um a very good morning and warm regards to all of you. Okay,
Thank you.
so um, so hello. So
Hello.
I'm on a duty travel.
Yes, great.
Okay. So to answer the question, actually, Dr. Pronab Dada has already mentioned everything from our side, but I would like to answer your question from laboratory perspective, as I'm a
Yes.
laboratory person, and I'm very proud to share information on behalf of Bangladesh NTP that we do have a very strong network of molecular laboratories. If you see 5 years back, we only have around 200 gene expert laboratories, which was very minimal to support our full country. But now, with the great efforts of NTP, we have around 735 gene expert machines in our country, including 88 16 module machine that is the most upgraded gene expert system. Soon, this number will be 840 throughout the country by the end of this year. We can proudly say that from the beginning with each district to each sub-district, we do have molecular laboratories for the diagnosis of TB. The challenges with expert lab setup is the cost behind to provide the uninterrupted power supply, air-conditioned room, dust-free environment. But we also overcome this issue by introducing the most recent technology, that is TrueNet, in 2022 in our program, which have no additional laboratory setup requirement, could be operated by battery, easy to handle, portable, and thus could be set at below sub-district hard to reach areas with limited space and electric capacity. Those are the laboratories we used to call the peripheral labs. So now we are successfully running around 38 peripheral TrueNet laboratories, and this number will be 112 shortly. Additionally, for the clinical diagnosis purpose, we do have 242 X-ray machines throughout the country with 40 portable machines with AI system. So actually, these are the laboratory capacity of our country, which we are expanding to decrease the number to decrease the gap between that and decrease the gap between the notification and diagnosis, and to increase the diagnosis throughout the country. And with this huge network of molecular tools and molecular labs, we are targeting, and we know that we can cover approximate 70% coverage by 2026. So this is from the laboratory perspective, as Dr. Pranab has already mentioned everything, every limitations of our country and what we're doing. And this is from the laboratory side I want to mention in this forum. Over from my side.
Thank you very much. Thank you, Tasnim, for letting us know about your lab capacities, and with people like you at the helm of affairs, I'm sure that is going to pick up very rapidly, as you said. Now I invite Sarder Tanzir Hossain.
Good morning, Shobha. Am I audible?
Yes, you are audible, sir.
Yeah,
yes.
So actually Dr. Pranab and myself will sit together,
Okay.
in NTP's conference room. At the beginning, my heartfelt gratitude and thank you very much for inviting us. Particularly, it's a great thanks for Sumit Dada. Actually, he connected all of us with you. So it's a great pleasure to have the opportunity to discuss about the progress of Bangladesh National TB Control Program, about so achieving the NTB strategy, and what are the challenges and how we can overcome those challenges. as you see, what in your question you mentioned, pointed very correctly, what NTP has been doing to tackle the missing cases. So I will start my talk with an example. So what NTP has been doing, if you see last year, 2021, NTP actually introduced the TrueNet in Bangladesh, which is a near point of care technology. It's a 38 peripheral setting, because the current level of molecular technology cannot go below the upazila level, which is called the sub-district level. So now the TrueNet is more closer to the community. So at the community level, 38 area, NTP introduced the TrueNet, and we compare the data before TrueNet and after TrueNet. On that area, before TrueNet, there was only microscopy. Yeah, and when the TrueNet implemented, and you see one of the indicator, you will find the WHO 2022 global TB report. There was only 24% people has the molecular access to the molecular test at the initial test, But when we introduced the TrueNet, before TrueNet, there was a 4%. There was only 4% people have access to the molecular test at the initial TB diagnostic, and within 3 months, 83% people have access to the molecular test at the initial TB diagnostic. So this is an example how NTP actually moving towards achieving the NTP strategy. Not only this, on that area, before TrueNet, the last 3 months, there was no rifampicin TB cases diagnosed in that locality. But after TrueNet, 25 rifampicin resistant TB cases diagnosed. So with that, actually, I will describe some of the scenario. So yeah, so one of the strategy of the NTP is early diagnosis and find all TB cases. With using the rapid molecular tools that my colleague, Dr. Pronab and Maliha very nicely portrayed. So NTP has a massive scale-up plan to cover till the community level, to the for community level, to establish the molecular test for all the people, so that all the people have access to the molecular tools. One thing, another thing is, NTP is also, they have the very strengthening the monitoring system as well as the treatment and care system. NTP also, they have partnership with the BRAC, Damien Foundation, such kind of so many NGOs in Bangladesh. Through this connection, they are also mobilizing the, TB treatment, so that every TB diagnosed TB patient link with the treatment as soon as possible. Through this way, we'd be able to actually prevent the morbidity, and as well as reduce the chances of transmission. Thirdly, NTP also, what we have been following is strategies: diagnose, find and treat, which is diagnosis and treatment. But beyond that, there is the infection transmission dynamics, which is, every 3 people out of 3 people, one people is TB infected. So we all are the reservoir of TB bacilli. So TB preventive therapy is mandatory if we actually really end this, this TB by 2030. So NTP also has started and scaling up the TB preventive therapy at all child, so that it can also prevent the infection as well. Also, TB, if you see the lens of our health system, if you see the our health system through the lens of TB, then there are so many underlying health condition, determinant factor, which also need to be addressed, is a cross-cutting with the other, health service delivery. NTP also moving toward integration with the other health service, partner and the other health service authorities, so that the social determinant of TB, the system strengthening, and the service system, is getting strengthened day by day. That will actually ensure the better TB services for the community people. And also, what is more important, if you see that the missing cases is one is technological gap, because the microscopy is less sensitive than the molecular tools, and we actually lose many of the cases through microscopy. But there is also issue with the health-seeking behavior among the community people. Is still, despite all this effort, is still our country, like any other country, is not free of stigma. So there is a social initiative. NTP has a very advocacy program, sensitization at all levels to aware the people so that they can easily, frankly, openly, they can seek the care for TB test and treatment whenever they feel symptomatic, as well as NTP also accelerating the active case findings so that they can reach to the every home to find the presumptive TB patient, as well as the how NTP can bring the asymptomatic TB patient under the treatment screening and the treatment cascade. This is also ongoing, and also the vulnerable population, like I mentioned the TrueNet technology, because there is a very remote area in Bangladesh. There is a lack of electricity, communication is disrupted. And these people are, there are so many factors that actually creating the barrier to getting, having access to the TB services. So NTP is actually tailoring the program for those people, like you see the garments population. They actually work from 7 a.m. to like 8 p.m. at night. So they don't have time in the daytime to seek care for the TB. So there are some of the area like, the late night clinic services. Some of the population like the fishermen, they go for the fishing for the like for a week. So NTP is taking care of all this consideration, the vulnerable population, what their needs, and they're to try to customizing their programs to fulfill their needs, as well as, so NTP's the current national TB strategic plan, which is actually in 2024 and 2030, which is clearly mentioned to reduce the burden of TB incidence by 2030 is 70,000, 70,000, which is currently like a incidence currently. Allow me 1 minute, so I have a just figure. Yeah. Just a minute. Oh, yeah, which is currently 300,000 and 380,000. So all these efforts. So if I can sum up my discussion, so NTP is rapidly scaling up the molecular tools, which is appropriate for the tier and appropriate for the different level, like a gene expert up to a Upojala, below Upojala is TrueNet. Then NTP is improving the treatment care, linking with the treatment promptly. So they are using the digital technologies. It's a digital adherence, I would say, like a aspect system. There is the ETB manager, so connecting all these things. As well as NTP also is partnering with the donor like USAID, Stop TB, and it has also the collaboration with the very prominent, largest NGO like the BRAC, Demand Foundation, the other, and it also collaborating with the other government stakeholder like a PJON, Ministry of Defense, Roads and Highways, so that TB is not a program with the problem of the health ministry. Is a problem for everyone. They are involving. Also, NTP is working to ensure reduce the financial catastrophe of the TB patient, reduce the stigma, and ensuring the human rights, at the intervention. And overall, NTP is, trying to make the TB services is a people-centered care. So through this thing, so over from my side.
Thank you very much, Tanzir, and thanks for pointing out that it is not just the responsibility of the health department, but all of us because there are so many social determinants of tuberculosis, as you have pointed out rightly. So that is important. It has to be a joint effort. Now I invite Dr. Shayla Islam from BRAC.
Am I audible, Shobha?
Yes, Shayla, you are very audible. Yes.
Yeah. So good morning, everyone. And thank you, Shobha, and thank you, Sumit Dada, for giving me the opportunity to speak up here. And first of all, for reaching the unreached, I would like to say that my three colleagues previously actually very nicely mentioned some of the issues that NTP, some of the initiatives that NTP has taken throughout the country. So I would like first focus, as I am working in BRAC, and BRAC is a community-based organization and working throughout the country with along with its partners. So I would focus on the people-centered. That was the last sentence from Tanzir. And people-centered approach and community-based, that are very much necessary. And the activities, we can focus on the active case findings, community mobilization, and under active case finding, we have some of the activities in the community to reaching the unreached. So those are community mobilization, doing the community outreach by engaging community volunteer who are the people of the community. And from those outreach and through the different mobilization activities from the community, we are transporting sputum to the facilities for testing. As my previous colleagues has mentioned, that we have now more than 400 peripheral lab. We also call those the second lab. So NTP is actually scaling it up this year, another 112. So altogether, we are doing testing by TrueNut in total 150 throughout the country. So with this, I think we can find all TB and treat. We'll be able to treat all TB in the country with the guidance of National Tuberculosis Control Program. And our government is very much committed on that part and very much in line along with its partner to end the TB from the country. So another thing, we have to apply multiple strategy, engaging multiple sectors, like I can add some of the various places other than health sector, like workplace, prisons, and other private facilities, and some other private healthcare providers. So in that case, I would like to mention that NTP has its focus on the graduate private practitioners, medical experts throughout the country. They have oriented. So it has been able for, we are actually benefited from those orientation to the medical experts by NTP. So we are getting some presumptives from those experts, as well as some diagnosed cases from those experts. For even in some cases, they are actually requesting us for doing the molecular testing directly to some of the presumptives. So that is one thing. And another thing, NTP has started and we are implementing in the community, that is screening among the vulnerable and marginalized group of the community, like children, elderly. As in our last prevalence survey, we got that TB is much more prevalent in the aged population. And we are also doing some screening in some very hard to reach or remote areas like coastal belt and hilly areas of the country, and in some targeted groups like ethnic groups. Those are actually placed in different geographic areas of the country. And we are for stopping the missing TB cases. We are also increasing the testing as much as possible by expert or TrueNut instead of microscopy, as we all know that through microscopy we are missing many cases. We have actually experienced that in microscopy the case positivity rate is around 4%, where through TrueNut is more than 7%, as well as through Gene Expert is more than 10% in our country. So as it has been scaled up already and is going to scale up much more throughout the country, so we had scope to do the testing of TB presumptive through molecular testing. And we are also doing, with the support of NTP, some contact screening or contact investigation of the index TB cases, whether they have symptoms, to get the infection and to cut the infection chain. And actually, we are doing the testing of symptoms, who have the symptoms, and if there is no symptoms, we are doing the with the support of a medical doctor, we are initiating the TB preventive therapy in the country. So that is another initiative by NTP in the country. Another thing I would like to say that from the last year, actually NTP has started the ambulatory treatment for DRTB patients in the community. From the 0th day they are getting treatment. So that is also another initiative to cut the for early diagnosis and treatment and to cut the infection chain. Because we have experienced earlier that many DRTB patients are absconded and actually refuse to take the medicine when they are admitted for a prolonged time in the hospital. So in that case, we are hopeful to increase or ensure the treatment adherence for those TB patients in the community from the 0 day. And another lasting thing I would like to focus that the private sector engagement, that in some of the places we are missing. Actually, in the large hospital, there are huge queue in the outdoor as well as some indoor patients. We should screen those, or we should focus to screen those respiratory symptoms related presumptive. And to test them. So in that case, in the upcoming years, we are also planning to do some screening on those large public as well as private hospitals for getting much more missing TB cases from the private sectors. So I think NTP is very much in line that I previously mentioned already, along with its partners to end TB finally. And we are hopeful to end TB by 2035 from the country. Thank you. Thank you very much.
Thank you very much, Shayla, and thanks and all force to you all. And thanks for mentioning that community-based interventions involving community are really very, very important. Sometimes we miss out on that, and your organization, as it is concentrating in that area. So we hope for good results. And I now hand over the mic to Nurul to conduct the second round. Over to you, Nurul.
Sorry, Shobha.
Yes, you're there.
Okay. Thank you. Thank you all. I was just hearing the wonderful discussion. So in the second round, so basically our speakers already mentioned a lot of issues on what is happening in Bangladesh, and you cited the report of the WHO 2023 TB report. And in that report, we have seen that Bangladesh actually walked backwards in terms of case detection and treatment coverage in 2022 compared to 2021. So there are some issues that we know from here in Bangladesh with the BRAC and the government, and there are some transition kind of things. But good news is that Dr. Pronab in his speech said that they are doing better now. So hopefully we'll get good results in future, near future. So in the second round, my question will be, you already discussed about replacing the microscopy issue. So my question will be, WHO has called upon countries for replacing microscopy 100% with upfront molecular diagnostic test by 2027, which is of course vital to find all TB and also to help us stop spread of infection. And WHO Global TB report, the report that I have mentioned before, that report shows that 20% of notified TB patients in Bangladesh had a molecular test diagnosis. So please share what Bangladesh is doing and what more can be done to stop missing TB cases among those who take a TB test. And microscopy misses a lot of those with TB. Please also share how all those diagnosed are linked to care and supported through the treatment to reach the cure line. So I think we'll follow the same order. I mean, I would invite Dr. Pronab Kumar Modak, Deputy Program Manager, Training, National TB Control Program, Bangladesh, to start with.
Thank you, Mr. Nurul. Nicely presenting and nice questions. So basically, you are exactly point out so what the WHO's recommendation is that, and also NTP with aware about the recommendations, and we try to reach the exact figure. So we have to make it by stepwise manner, because previously in TB control programs we have more than thousands of microscopy centers. Those centers were using to diagnose that the TB patients. But day by day, we are scale up, replace the molecular technology in the hospital-based manner. Especially, we are focusing to cover the Bangladesh through the Upazila Health Complex basis, and also we are scaling up in the district level, district hospitals, and in medical college hospitals, we are also place those technologies. The area where there is a huge gap is the urban area, because in the urban settings we don't have this health structure channel. So basically, in the urban region, a lot of people are living in the urban area right now. So to cover those urban populations, with the help of our NGO partners, we established some diagnostic centers. We called it through private.
We cannot hear you, Dr. Modak.
Yes, we've lost him again because of
we
poor
lost his
connection. Yes.
So shall I wait, or
let us wait, I think, maybe
okay,
for a little while, and then
sure,
maybe he comes back, because he has a weak connection. He said that.
I think we can
yes,
switch to the next speaker,
yes, yes,
and then
yes,
if he comes again, then we can
yes,
give them slot again.
yes,
So
yes, sure.
now I would
Sorry,
like
Nurul.
to. Oh yeah, please go ahead. Go ahead.
I'm very much sorry for the connectivity.
No problem.
issues.
Please go ahead.
So what happens to cover those peripheral areas with the help of our partner NGOs, we are basically replace those microscopy centers through TrueNet machines, because WHO right now recommended to replace those microscopy center by TrueNet, as TrueNet is also the PCR machine technologies. So we have the number of more than around 430 peripheral labs currently serving as a diagnostic tools in the remote area. So out of those more than 400, we right now we are able to cover 150 areas. So again, around 300 areas yet not we are covering. So it is in our headache, and also, of course, with the help of our donor agencies. Especially, I mentioned the name of Global Fund, because Global Fund is the major donor agencies in the current TB control program, and also support of USAID. We are plan how to minimize those gaps, how to cover those 300 areas where the microscopy till now, the primary diagnostic tools. So hopefully, if fund is available and we can procure more molecular technologies to place over there. So this is the current status, as we have not too much fund right now in our hand to procure those molecular technology. What should we have to place of those area? Right now, those 300 peripheral laboratories are currently out of reaching the molecular technology. But again, we have good connectivity and relation with our NGO partners. So we are trying to referring the samples. We are collecting the samples from those area and referring those samples to nearby molecular technologies. By this manner, we are trying to minimize the gaps. But again, if we want to test all of those presumptive cases, we need diagnostic kit also, because we have machines right now in the areas or nearby areas. But again, if we want to test, we need some cartridges or kits. So these also funding gaps we are facing right now. So we are trying to minimize those gaps. And with the help of our donor fund, we try to increase the investment in the diagnostic area also. So this is the ongoing process, but currently you mentioned in the previous WHO report, the coverage is around 27% like this. But last year, what we observed in the data, it is around like 35 to 37% coverage. And in the current year, that means 2024 to upwards, it is increasing. And by 2026, it will be maybe around more than 70%. So, but again, it is in our mind that we have to cover 100%. So we are trying to minimize those gaps. And as much as possible, so we test through molecular technology. That is from my side. Thank you so much.
Thank you, Dr. Pronab. Thank you, NTP, for your effort, and hopefully you will reach your target. So now I would like to request Ms. Umme Tasnim Maliha, microbiologist. She works in the lab, so to speak on the question I asked before.
Okay, thank you, Nurul. Am I audible?
Yes, please go ahead.
Okay. So as I have already mentioned in my previous comment that we have already covered each district and luckily each sub-district with molecular labs. But definitely, as Dr. Pronab has mentioned, that we have left 300 or more peripheral labs with, primary diagnostic tools as LED microscope. But we are planning to replace those LED microscopes with molecular tools, but there is a funding issue. So it's not possible within the current funding to replace all the microscopes with molecular tools. But and the better thing is this, that most of the microscopy labs have a nearby Gene Expert or TrueNet lab. And with the help of our partner NGOs, we are actually referring the samples to that molecular labs. And also, our recent current diagnostic algorithm is designed in such a way that each AB positive must be tested with molecular tools. So whenever we are finding any AB positive in microscopy labs, we are referring those samples to molecular laboratories like Expert or TrueNet sites. And these microscopy laboratories have nearby DOT sites for treatment initiation as well. But apart from this, definitely there are limitations. Bangladesh is a country with lots of rivers, and we have hilly, hard to reach areas, coastal areas, versatile socio-economic condition, sample transportation barrier is there, and most importantly, there are lack of sensitization. So we have diagnostic facilities, but general people need to know that. Even the clinicians, the people's working in the health sector, they need to know that where the TB diagnostic facilities are, where to send the samples, because that will only help us to increase the coverage. So this is the thing. So I think with the expansion of molecular tools, with the replacement of microscopies, we also need to let people know about our activities, about our facilities, about our capacity to decrease the gap. With the current molecular laboratories, or with the current capacity, we have we can provide coverage more than 80% with our current capacity. But again, we need the consumables, we need the cartridges, we need kits, we need funding for that. But with the current funding we have, we can only provide more than 50 or 60% coverage. But we have the capacity to cover 80%. So these are all the things our management need to think, our government need to think about us to support the TB program. Our main donor is the Global Fund, and we are getting support from USAID. But definitely our government should do some more, provide some more support to us, so that we can utilize the capacity we have to end the TB. Thank you.
So thank you. So now I would request Sarder Tanzir Hossain, Senior Project Officer with the Stop TB Partnership. He is a public health expert and formerly part of Global Laboratory Initiative, a Stop TB Initiative, WHO, to speak on the issue.
Thank you, Mr. Nurul. Yeah, this is a very important topic, and very, we all agree that we need to actually scale up the molecular tools to the up to the lowest tier of our health facilities. But yeah, but still, with the current advancement of technologies, the microscopy is needed. Yes, we are replacing it for the diagnostic of TB patient, but treatment follow-up perspective, the microscopy is still needed. So we can replace for diagnostic, but we cannot eliminate. Yeah, one thing. Yeah, also, my previous two colleagues, Maliha and Dr. Pronab, they clearly mentioned NTP has been trying with their best, with the available resources, with the available technologies to cover the east tier of health facility in Bangladesh. But still, this is not sufficient. Why this is not sufficient? Because earlier we have only the gene expert technology, which is also still it need electricity continuous support. It needs air cooling support to operate this machine at the Upazila level, and it needs a very the control environment to operate the gene expert machine. And the amount of tests it can perform, it is not enough to actually the demand that the number of presumptive TB patients come from the Upazila level. So there is unmet need and the gap remain. Then there is a new development in the TrueNight technology. It's also molecular technology, and it can go further below, down to the Upazila or sub-district level. So yeah, NTP already introduced this technology in 38 sites to enhance the access of the community people to the molecular tools as a TB and the drug-resistant tuberculosis diagnosis tools. But this is still in the second lab, the peripheral level, and NTP also scaling it up. Now it will be soon it will be 150 from 38 to, because 120 machine already in the machine. It is under process for the installation. So yeah, so whatever technology and resources available, NTP is doing best. But in the TB, actually, we really want to end this TB, and eliminate this TB, which is the global plan 2022 and 2030, and the NTB study 2035. Then we need to optimize our resources, what we have, best use, and we need the technologies which like the pregnancy kit. Anyone can test their the pregnancy test within the room. And like the COVID, the antigen test. Yeah. So this is the simplified molecular test, which is the dream. That actually enable the access to every city, every people to their doorstep to the services. So which is actually, I know the global coalition is working on it. Also, another thing, yes, with this current level of achievement, my NTP colleagues, we all are optimistic and we have a, sense of satisfaction. But there is a, sense of concern as well, all this thing has been funded and dependent is a very donor driven dependency. But if you see the last global TB report 2022, the domestic funding is 11%, which is the total TB expenditure budget, So yeah, so NTP is doing its best, but simultaneously, for replacing the microscopy at all chair and introducing the molecular tools like the TrueNet, and there will be now more, sophisticated tools, which will be more people-centered, enable the more people-centered care. But for the sustainability perspective, technological advancement, and the country actually would decide which is work best for the country within the economic structure, the disease burden, and the external funding support. So through this, that's over from my part. Thank you.
Yeah, thank you. So now I would request Dr. Shayla Islam, an associate director with the BRAC, which works at the field level, to speak on the issue, and also please also share how all those diagnosed cases are linked to care actually. So, Dr. Shayla Islam.
Yeah. Thank you, Nurul Bhai, for giving me the opportunity again. So basically, I would echo with my three of my previous colleagues that country has opportunity actually to diagnose the TB cases. But we have some limitations throughout the country, and you have already mentioned that from the WHO report that in 2022 that has been published in 2023, and that we have already covered 20% through molecular diagnostics. But if you see the picture of 2023, I think it's a little bit improved throughout the country. In some regions, we have even saw the significant improvement. But in 2024, as we mentioned, many of the sub-district as well as districts will be covered by TrueNet as well as gene expert machines. So we are very much positive and hopeful that we are going to do it more and more. So we have planned to do the diagnostic molecular diagnostic coverage in 2024 around 50%, and then as Dr. Pranab already mentioned, we phase wise we have planned to do it 70%, 80%, and then we have in our plan in our head to do it 100% to replace the microscopy from the country. So that is one thing. But another thing, two of my previous colleagues already mentions some of the challenges. So supply is actually another challenge. So funding another challenge, resource that we call actually resource. So we are still donor dependent. So in that case, we'll have to think differently, and we will have to engage multiple sector, including the community, and we will have to strengthen the system, not only the health system, facility-based health system, but also the community system strengthening. So those are the things I think I and my colleagues are already covered. But the second one that Nurul Bhai asked me to link, so this is if I see the community, if I start from the community, so we are doing the active case finding in the community. How we are doing that? We are reaching the household through our community health volunteer, doing the community mobilization. We are doing some special outreach in the hard to reach and remote areas through the community people. As a volunteer, we train those guys in the community and promote them for doing the for collection of sputum and doing the staining and doing microscopy. But whenever we have started as pilot, as Dr. Tanzir, Mr. Tanzir has already mentioned, that we have done a pilot on 38 tuners in the below sub-district level. That is actually the union level, and most of those are placed in the government facilities like FWC, Family Welfare Center, or sub-centers, or those places. So in these cases, we from the community, our community health worker are transporting the sputum from a community to those facilities for testing, wherever which are available. Like in some cases, most of the cases, microscopy are available. So we are doing largely microscopy. But some of the cases, the TB presumptives are also sputum of the TB presumptives are also transferred to the Upajala health complexes for gene expert testing. But I think still we have to work on that part to strengthen that sputum transportation process from the community to the facility for the better diagnosis. And after diagnosis, we again, after confirming the TB patient, we again select a DOT provider through our Shastro Shebika, we call them, community health volunteer, or some of other DOT provider, or in some cases, even if the patients want to keep it confidential, in that cases, we actually fix the family member to provide the directly observed treatment in the community. So that is the linkage we are doing at this moment. But I think from 2024, according to our national strategic plan for TB, we would be able to do something, but there will be limitations, and definitely NTP management as well as health ministry and its partners are planning to do much more for ending TB from Bangladesh. Thank you very much.
Thank you so much. I think we have covered all the panelists at this point of time, so I would like to hand over the mic to my other co-moderator, Shobha Shukla. Shobha, are you
yes.
there? Yes.
Yes.
It's your turn. Your turn. Thank you.
Thank you, Nurul. Thank you. And I now invite Mr. Sumit Mitra to share his thoughts on the point of care diagnostics. Over to you, sir.
Good morning to you, Shobha. Good morning, Nurul Bhai. Good morning, Tanzir Bhai. Good morning, Maliha Appa. Good morning, Shayla ma'am. Pronab da. It is a great feeling first to be part of such an elite panel. As they say, the person who speaks last has actually a very easy job, because there is not much for him to say, because the experts have already said everything. I will, however, try to just put my thoughts from life in general and link it to TB, because the call is to find all TB to end TB. They say that life, we have one life, and they all say that it is just an outcome of the choices we make. And they also say, the saying also goes, that every choice that we make has a consequence. So nothing in the life and no choice that we make ever goes without a consequence, and nothing is ever free. So I'll try to link this to basic fundamentals, which again, the late Stephen Covey has umpteen number of times said that the only way that human beings are different from the animal world is in our ability to choose. That's the only way we are different from the animal kingdom. So with this, I'll try and link to what a great work the National TB Program in Bangladesh is doing. I have met all the speakers in person, and I have known them over the last couple of years. I know the passion that they have for their job, the yeoman work that they do beyond the regular hours of office. So the NTP, through all these young, passionate members, have chosen to bring in technologies changing with the times, dependent and guided by the WHO mandates. They have chosen to not kind of keep it within the confines of the Ministry of Health only. And I was so happy to learn, as Shayla ma'am said, that they have now gone across ministries, because TB is everywhere, within the army, within the prisons, within the schools, the colleges, wherever. So that's another great thing that the NTP has chosen to do. Tanzir Bhai has also mentioned that the algorithms are being curated, they are being customized as time progresses, depending on what the recommendations are, because one size doesn't fit everybody. So the guidelines are ever changing, the guidelines are ever dynamic. So even the ultimate results in terms of the algorithms being chosen are also dynamic. So the NTP has chosen to remain alive and, with in sync with the times, so to speak. So when the NTP is making all these choices, what is the only outcome possible? And the only outcome that we all crave for under the TB program is the elimination of the TB, the historical burden, the curse which is on us by the year 2030 or 2035. So again, great work by the National TB Program in choosing to do everything that is required, in choosing to do everything that is within the realms of the reality. And I will touch upon 1 or 2 points here, which has been mentioned both by Tanzir Bhai, by Shayla ma'am, in terms of financing. India, Bangladesh, part of the SAARC, we are not very financially developed countries. So we are all developing countries. So our finances are a constraint. So that is where I think the people like Nurul Bhai, through information dissemination to all other stakeholders like corporates, like, big companies. And I'll take the example of India, how we have done in India. We have gotten a lot of these big companies through their corporate social responsibility to donate to TB diagnostics. And they have done so heavily. While I cannot commit, but part of our own ethos, that is the company that I work for, and everybody knows that, we are also trying to do something which is known as the neighborhood first policy. We plan to do a lot for our immediate neighboring countries like Bangladesh, Sri Lanka, Nepal, etc. Not only for the TB program, but also for other infectious diseases, so that, the burden of diseases are not on us. And we as a proactive society can take steps to lessen the burden of these diseases. So we will do whatever we can. We will try to generate funds from our end and see if we can help our immediate neighboring countries. Bangladesh is very high on our agenda. So in ending, I will just say that keep the good work up. There is no doubt in anybody's mind that the ultimate goal of eliminating TB through appropriate choice of technologies, and there are so many today, as Tanzir Bhai again said, our company too is very mindful of the changing landscape of technologies, trying to develop very, very simplistic, rapid tests which people can do in their homes, in the confines of their home, so that the social stigma doesn't come to haunt them, etc., is all being worked out. We have no doubt that together, putting everything that is within the realms of possibility, we will do everything that we can to ensure that we have not only the financial resources available, we will also generate resources from within the country. And that is where I call upon Nurul Bhai and people passionate in Bangladesh, in the media in Bangladesh, to disseminate the information and try and figure out where resources can be garnered. Because once we start trying, we will be amazed to know from where you can get money. And people are actually today, after the pandemic, waiting to give money for healthcare because everybody realized, and I think the pandemic has taught us this great lesson, that nowhere better to use CSR funds than for healthcare. So with this, I would want to pause and just last words again. The choices that you are making, NTP Bangladesh, each one of you will only have one consequence, and that is elimination of TB by 2035. Thank you so much for this opportunity. Thank you very much again. Over.
Thank you, Sumit. Thank you for energizing us so much at this hour, which is very unearthly for you, because I believe Sumit is in Brazil and it must be very, very early hours of the morning for him. Thanks for being with us. Now, before we open for the question and answers, can we please have a short and crisp message from each one of our speakers for World TB Day 2024? Your 1-minute message, please. We can follow any order. Or should I? Okay, Dr. Modak, your crisp message for World TB Day 2024.
Okay.
Yes.
Thank you, Shobha, for your nice hosting, and I thanks to Sumit for joining, even though he is now in Brazil. So Sumit is a very good friend to us, and his intention is to support as much as possible from his company. So basically, my message is very clear. We all are working here to eliminate TB from our country, and if we are able to do this, it is the global necessity also, because each and every country is doing like this. Ultimately, we are able to eliminate TB from the world, because if I do this by only, or if I am not doing this, is any country is doing this, he is not basically make sure and make secure, because the nearby country will have the burden. So each and everybody, we have to work together, and if we do together and make initiatives, because the current now the technology is very much in front, so we are able to use those technology. And upcoming, we are waiting for the vaccines also, and we are also initiative TB preventive treatment, which we are not basically mentioning previously. It is also a very good initiatives, global initiative, what I like to mention. So incorporating all those things, we are in a right track, but again, we have to strengthen all of those initiatives. That is from my side. Thank you.
Thank you. Tasnim, your message.
Thank you, Shobha. Actually, nothing more to say. Just to my knowledge, I think the motto of World TB Day should be like to let people know about TB, both the worst part of TB, that what could happen if we leave TB undiagnosed or untreated, and the best achievements of TB pills. And thank you again.
Okay. A message from Tanzir for World TB Day.
Thank you, Shobha. Yeah, actually, our motto, passion, and commitment is completely aligned with the NTB strategy. So yes, our message and is always the same till we can, end this, this TB burden. So yes, we can end TB for 2024 World TB Day. This is my message. Thank you very much.
Dr. Shayla, your message.
Yes, my message is to focus on actually policy advocacy in the country, engaging interministerial policymakers to increase domestic investment, that is domestic financing, domestic resources, to reduce donor dependency, and to ensure the sustainability so that we can all work together with confidence and can end TB. Thank you.
Thank you, Shayla. And Sumit, your message.
If you allow me, I will use my mother tongue and I will then translate it to English.
Sure.
যতক্ষণ আমরা টিবির শেষ দেখবো না আমরা থামবো না, যতক্ষণ আমরা টিবির শেষ দেখবো না আমরা যা যা দরকার একসাথে করতে থাকবো, আমরা তখন থামবো যখন টিবি শেষ হবে. Translating into English, and I echo every word that Tanzir Bhai, Dr. Pranab, Shayla ma'am, Maliha ma'am has spoken. Together we will do everything that is required. Together we will do everything that is the necessity of the day till we see the end of TB. And when I say everything, that would include getting resources, getting everybody, all the multi-stakeholders and everything else. So that's the motto, that together we will win and TB has to go. Thank you.
Nurul, can we have a message from you also?
From me?
Yes.
Just one line. So the line is that don't forget TB and ensure molecular diagnostic tests.
Okay, great. We can now take up a few questions and comments from the participants. So if you have any question, please type in the chat box. We already have a question from Zafar Irshad, who says it is great to see impact of moving away from microscopy and using X-rays for screening and using molecular testing. Is this resulting in increase in case notification significantly? And also, can we test for HIV on the same machine or do we need a different one? And it's important he's talked about HIV because TB and HIV very often go hand in hand. So would any of the panelists like to answer this question?
Yes, Sobha. So
yes.
Can you hear me?
Yes, we can hear you. Yes.
Yeah, so this is a very excellent question. So yes, whenever we put the X-ray screening, like Dr. Maliha mentioned, the NTP is now introducing the portable X-ray, another thing Dr. Pranab also mentioned. If you just test the presumptive TB patient randomly through TrueNet or the GeneXpert, then the positivity is around 10%. But if we do the screening through the X-ray and find the suggestive tuberculosis cases and then get tested by the MWRD, which is we call the GeneXpert TrueNet, then the positivity rate increase till 30%. There is a global experiences. Yes. And the second part of the question is, yes, the TrueNet and the GeneXpert, the same machine, both machine can be used for the HIV detection purposes. Yeah, and NTP also using the GeneXpert machine for HIV detection and the viral load quantification purposes. Thank you.
Okay. Thank you. I believe the TrueNet machine can do a lot many tests. Sumit, can you just make a comment on that? Apart
yes,
from
you're right, Shobha. Yes, and the machines can actually do over 40 different tests as of now. HIV is one of them. In fact, Bangladesh, in the private market, they're already doing a lot of tests other than TB, like hepatitis B viral load, hepatitis C viral load, HLA-B27, and many other tests. But the HIV on the TrueNet, which is under the NTP, has not yet started. Once the funder agencies are in sync with the LTA for HIV, I'm sure the HIV testing will also start on the TrueNet machine.
Okay, thank you. In fact, I wanted to ask a question, and in continuation with that, there is a question from Anisul Haq. I want to know that how are those diagnoses it's a very, very important part. That is the first cog in the wheel. But how are those who are diagnosed with tuberculosis? What is their linkage to care? And how are they supported through the treatment? Do we have lost to follow-up cases? And to add to this question, Anisul asks, is it difficult to keep migrant people on treatment for long duration? So again, a case of losing to follow-up and what is being done about that?
Yeah. So thank you so much, and thank you for that questions. So basically, what happens? We are uh, doing the treatment, arrangement of treatment, and it is also free of cost.
And
And
those
those, hello, it
it
is
is
clear
clear
now
now
because
because
I
I
feel
feel
some
some
echo.
There is a lot of echo.
Yeah. Hello. Yeah. So echo is continuing. So okay, if it is audible, I can continue.
Yes, please continue.
So it is free of cost and arranged by the government of Bangladesh. So we have around 800 dots corner where the treatment facilities are available. So when any patient is diagnosed as a TB, we refer those cases to nearby the dot centers. And through these dot centers, each and every patient's treatment is continuing. But again, some very few percentage of patients have those who are not don't will to full the regimens because it is at least 6 months regimens. So we found some patients who are not willing to complete the courses. So through our community level worker, through government side or NGO side.
Now we have lost him.
Hello.
Hello. Yes, now we can hear you.
So our field level workers were try to track those patients and try to complete the treatment courses as much as possible. But few percentage, the number is very minimum. Coming to the second point, difficult in keeping the migrant people. It is not difficult to treat them because if we have the patient, if they are migrant, we give them the treatments. So as the patient is migrant, maybe the time of diagnosis he is residing in our country. So we provide them the full course of treatment, though it is not maintaining the DOTS procedure, but the patient's patient need basis, we are provide them the full course of treatments. And also we try to make some patients, relatives or any contact person in our contact list so that through them we can give some idea as this patient is maintaining his treatment or not. But what happens sometimes as patient is not residing in our country, after 15 or 1 month he is leave our country, it is very difficult to make the follow-up purpose. So through internet activity, connectivity like WhatsApp or other connectivity, we try to get some idea whether patient is getting his treatment, continuing his treatment or not. But actually the full course of follow-up purpose, it is not possible for the migrant people. But we are giving them the full course of treatment.
All right. Thank you. Nurul, are there any questions from your end? Or Nurul, are you there? I had one, not a question, but a comment. Tanzir, you were talking about that we are waiting actually for a very simplistic test like the pregnancy test or the COVID test with which we can test for TB. Even if hopefully we will get that someday. But then what about equitable access to these tests? The COVID test you're talking of, that was not easily accessible to everyone. So should we not also work on the front of equitable access to whatever science has to offer us?
Should I add something?
Yes. I want to, yes, your thoughts on that.
Hello.
Yes, hello.
Yeah, this is a very, very, very legitimate question because we have experience for the recent pandemic, the COVID-19 vaccine distribution, you see,
Yes.
and the diagnostic kits, and we see the discrimination happen at the different time. Yeah, so I think there should be a global caucus or global forum, which is, allow the WHO, Stop TB, donor, even the manufacturer, they come forward. As Sumit was mentioning, as a company, they have their social responsibility, for the humanity. So I think from the very beginning, whatever the manufacturer who developed this kind of, dream, tools or testing kits, it should be a very fair price for the developing country like us, LDC country for us, so that our people have access to this, the government has access to this, kits. Otherwise, if it is like a, still, it's not only still Gene Expert cartridge is a 7 USD per test. TrueNet is a 7 USD. But it is, yeah. But if you calculate everything, it will go beyond the 10 USD. But it is still not, the fair price for the developing. And I know we understand there is a manufacturing cost and other things, but we need some sort of, mechanism where everyone will have the access this kind of, advancement of the innovation by their government, so that every people, wherever he stay, we belong to the same planet and everyone have the equal access and equitable access for these testing services. Over to you. Thank you.
Thank you. I now hand over the mic to Nurul for the closing remarks. Over to you, Nurul.
Oh, sorry, I was just away. So can I? So the question answer session is already.
Yeah, yes, I had asked if you have any questions, you may please ask and then close the session.
No, I had just a simple question. So what about the funding issue? Because we know there is some funding support from outside. So is there any concern, I mean, regarding the funding issue? Anyone from the NTP can speak on that?
Yeah. So, totally. So basically regarding the funding, we are now developing our upcoming operational plans, because from the government side, the portion what is budgeted from the government side, it is reflected in the operational plan, because it is a separate program, vertical programs. So previously in the 5 years operational plans, so we don't able to keep as much budget as possible, but in the upcoming operational plans, so we are trying to increase the budget from the government side. So again, it is not fulfill the gap, because if you go through the WHO report, you find out that there is a huge gap, at least more than 40% budgetary gap over there. In terms of having the government funding and also funding from the external sources. But again, if we increase the government budget, it will not fulfill the more than 40% gaps. So we can minimize the gaps a little bit. So we are trying to sensitize our higher authorities. Our Honorable Prime Minister also aware about this. She has the intention to more vibrant our programs like India. So we are trying. So as it is a ministry level activities, and also several stakeholders are involved in this process. So it is happening. So maybe in the next year, not next year, this year, the operation plan will be hopefully launched. So when it is finalized, we have some ideas how much budgetary implications reflected in the operational plan.
Okay, thank you. So basically, Shobha, I think from my side, there is nothing to add after this very extensive discussion. So I will just add, say one line that, in Bangladesh government, that just now Dr. Pronab was saying that our Prime Minister is, working on that, and she, because of that, the government budget they are going to increase in the next program. So the thing is that the government is also, we are also planning to have Smart Bangladesh by 2040. So in Smart Bangladesh, I think tuberculosis should not be a public health concern. So that's all from me.
Okay. Thank you. With this, we come to the close of the session. Thank you, speakers, for finding time from your extremely busy schedules to enrich the session with your valuable insights. And thanks to the participants for being there. Namaste, till we meet again, and hope we meet again soon.
Thank you very much.
Thank you.
Thank you.
Bye.
Bye.